So, as an asthmatic who has been dealing with this disease my whole life, I've had a couple of exacerbations that really stick with me, and probably probably the one that that really stands out the most is when I was about 8 years old. I played soccer um, as a defender on our local kids soccer team, and I was raised knowing I had asthma, but never really paid much attention to it. I never had flare-ups really. I wasn't on any control medications. I just had my emergency inhaler of albuterol that I've never used up until that point because I for the most part I was a healthy kid. I just had this diagnosis since I was really little. But I never really paid much attention to it. So I played in sports. I ran around, did normal kid stuff. But some reason this day, as I was running up and down the soccer field trying to chase that ball, uh, I felt this tightness in my chest, and I couldn't breathe that much. And I started having this audible wheeze, and I I actually ended up stopping and laying down on the field. I didn't pass out, but if I continued pushing myself, I would have. My parents were thankful enough to remember to bring my inhaler that day, and they gave it to me. But when it didn't improve at all, I ended up being taken to our local hospital, and I spent a couple hours in the ER as they gave me continuous neb treatments and told me that I had an asthma exacerbation and I need to really watch that, and I can't really play sports anymore because of it. It changed my life, asthma and this particular exacerbation. I didn't listen to the instructions that I was given by that ER physician regarding this disease, but and that led to a couple of more issues further in my childhood. But it's a scary thing having an exacerbation, and it's not just asthmatics that have these problems. It's any of the patients that have some of the five obstructive disorders. That we have this handy mnemonic as respiratory therapists, CBABE, that we can use to remember the five obstructive disorders. And in order down that mnemonic, we start with cystic fibrosis. Then we go to chronic bronchitis, which I know doesn't start with a C, but it's bronchitis, but chronic, which one of my dear co-hosts will explain. Then we go to asthma, one that we always frequently hear about. Then we continue on to bronchiectasis, and then emphysema, the disorder you most often hear about with smoking. But these disorders are your bread and butter as a respiratory therapist. You'll see patients with them a lot, and we are the primary caregivers for them in regards to managing their diseases. Now, one of the most interesting diseases that is present from birth and sticks with these patients for their entire lives is cystic fibrosis. So, Tom,
Yeah,
do you want to
so
talk a little bit more about CF?
yeah, totally. I just find it interesting. Like, I always loved getting questions of, like on a test, like what are the obstructive respiratory disorders? Because there's only five, so that means pretty much everything else is a restrictive uh, problem. But anyways, cystic fibrosis, commonly known as like CF in the biz, but it usually starts out. It's something that presents itself at birth. It's usually an issue with the pancreas at first, which is kind of interesting because um, you don't usually think of a different organ affecting the lungs to the extent, especially one that's responsible for helping like, excrete bile and like insulin and stuff like that. But it starts with the pancreas. And over time, your secretions and stuff, they just get thicker and thicker and thicker. So eventually, cystic fibrosis, it progresses to start to affect the lungs, and you start to get heavy, heavy secretions building up in the lungs. So these patients are usually, um, if they're fortunate enough, they are able to have like a vest therapy device that they can use at home, which I'll talk a little bit more about later. They're also on mucolytics, which is a medication category that helps break up mucus. Because that's the biggest problem is they're, they're them trying to get these secretions out of their respiratory tract. So mucolytics, they're usually on a lot of different medications as well. But the vest therapy, I thought it was interesting. We actually had the opportunity in lab to put on one of these vests, and it's hooked up to uh, what would you say? Is it ran off of?
It's
How
a
does that
it's
work?
a
Is it
pneumatic
pneumatic?
device. So the
That's
way it
what I
works
thought.
is there's a motor in there that basically oscillates air through these tubes that inflate the vest sporadically that at high frequencies of oscillation cause it to basically vibrate.
So there's two tubes that, or at least the styles that we've used. There's two tubes that hook into the vest that the person is wearing, and then there's two tubes that attach to this pneumatic device that kind of it oscillates, like it goes back and forth, and that's what gives you this shake. And we cranked that puppy all the way up. I don't know about you guys, but I wanted to see. I really wanted to test the extent of this machine's capabilities. And yeah, I didn't think it was very pleasant at the highest setting. Granted, I don't think CF patients go to that extreme. They definitely wear a lot longer than what I wore. Like I think I maybe wore it for 5 minutes, if that. CF patients that usually wear it for like I hope my numbers are right. I think it was like 30 minutes to an hour and a half at a time, and they usually do multiple therapies on that a day, three to 5 usually. That's a lot of that's a big chunk of time out of your day, but that's something that these CF patients have to do in some situations to breathe effectively.
It is.
Those that aren't Yeah, yeah. Those that don't have the opportunity to have this equipment at home, there's several like CF clinics around where they can get therapies done like this.
Most of these patients, like it's tough because they are straight from birth, and so you get to see like little kids in these vests, which is hilarious because they're like laughing and cheeks shaking. But it also
Seven.
sucks because they're dealing with this like pretty severe disease from like birth.
Yeah. I actually have I don't know why I didn't think of this, but I have a niece that has this. Um, another type of therapy that they've been doing with my niece, because vest therapy, I imagine, is kind of expensive, and I bet you there's like insurance companies that almost like rent out that equipment, but she's so tiny, like they wouldn't be able to fit a vest on her. I know they have pretty small vests for like babies and stuff like that, but she is tiny. I don't know if they have them that small. So they gave my brother-in-law like these little foam hammer things. Like they look like a kid's toy, but they lay her on her belly, and he just kind of like whacks her back, which is, oh my gosh, I'm gonna botch this. CPT, chest percussion therapy.
Yeah, that sounds exactly like CPT.
Yeah, so that's CPT. You can also do it if you don't have the equipment. You kind of cup your hands. You want to make sure that you make like a cupping shape with your hands instead of just a flat hand. Because if you're just slapping their back, you're just gonna bruise them. With no, what it's not gonna be as effective. It's the cupping that helps break up those secretions in the lungs. And that's what I got on CF. Do you guys have anything you want to add on that?
Just a majority of the patients you'll see with cystic fibrosis will be young kids, and that's primarily because the disease will progressively get worse as they age, and I think the statistic is like a majority of CF patients don't make it past the age of 30.
Yeah, which is sad, but it's just a part of life.
Yep, unfortunate. But
I think these podcasts almost make me sound like a terrible person. It's just life.
well, Tom, it's just because it's the healthcare professional. You do become a little desensitized to some of these things, and it is a coping mechanism, as we've discussed in previous episodes.
Right.
But besides that, yes, you are a terrible person.
Yep.
But anyhow, that was just a bit about the first obstructive disease, cystic fibrosis, chronic bronchitis.
Yeah.
Trevor, I believe that's you.
Or bronchiectasis.
Yeah.
I
I
guess
think
you
I'll
could go
just knock out both of them while I'm here.
Yeah, sure.
There you go. Go ahead.
So the two B's in CBABE stand for chronic bronchitis or bronchiectasis. Chronic bronchitis, and correct me if I'm wrong, is it's defined as a persistent cough that is lasted. It lasts 4 months in at least 2 to 3 consecutive years. Is that correct?
I
I
believe
thought it
so.
was,
It could be three
I thought it was
months and 2 consecutive
I thought it
years.
was 3 months.
So 3 months of a persistent productive cough in 2 to 3 consecutive years. 2 years, I think.
We had a professor. I feel like if we were to give him a catchphrase, that's what it would be. The definition of chronic bronchitis.
Yeah.
A cough lasting 3 months, persisting for 2 years. Something like
Yeah. And so, yeah, chronic bronchitis is just a chronic disease, long-term disease, long-lasting of inflammation of the bronchi in the lungs. Um, it's going to cause a pretty productive cough. You're going to be coughing up a lot of stuff. It's actually pretty common. It happens a lot. The best treatment for this is just to maintain it, really. You use bronchodilators to help decrease that inflammation, open up the airways, as well as mucolytics are used to break down anything that might be in the lungs and to help get it out. And that kind of leads into bronchiectasis because chronic bronchitis, when untreated, often leads to bronchiectasis. And this is where there's actual permanent damage done to the bronchioles in the lungs. There's a lot of secretions that get stuck and immobilized in bronchiectasis. So just imagine like a tube or a tube, and that's like your bronchi. In bronchiectasis, those tubes get expanded in certain areas, which can cause pooling of secretions, which can make it extremely difficult to get out of your lungs. And it causes those secretions to kind of break down that tissue, that lung tissue that they're just sitting on the whole time, cause a lot of infections and issues. And the treatment is pretty much the same as bronchitis. You're gonna try to dilate those bronchi, but and use mucolytics to break down those secretions to make it easier to get out. But oftentimes, these are very hard to treat and to gain relief from, as all of these diseases are with obstructive diseases. But yeah.
Yeah, good quick summation of chronic bronchitis and bronchiectasis, both pretty linked conditions, but
Mhm.
still very distinct in their own ways. The next one, which is, as I talked a little bit earlier, is a little bit linked to my life, is asthma. Drew, I believe you wanted to talk a little bit about it.
Yeah, so there's actually two forms of asthma, kind of like an abnormal constriction of your airways, mainly like the bronchioles. And they constrict and they also start to form like sputum or mucus. And so it makes it really hard for the patient to breathe. Um, but you can really tell when someone's having an issue with asthma by like their accessory muscle usage. They're really having to struggle to breathe, and they're really having to put their whole body into breathing. You'll notice that maybe they might be a little tachycardic, having a really hard time breathing. You'll hear wheezing. Maybe they'll be kind of congested, especially in their cough. And they may even be wet and clammy. But the main thing that we do to help um, intervene when we start seeing our patients with asthma is we give them oxygen therapy, and we also use aerosolized bronchodilators, things like albuterol or duoneb or things like that to kind of help expand those constricted airways that the patient's having. Um, and then one thing that I've seen that suggested is to also promote pulmonary hygiene. I'm not entirely sure what that consists of, but that would be something you'd want to talk to like a doctor with if you're a patient that's dealing with it, or if you're wanting to help this patient with managing their asthma exacerbations. But the other thing too with asthma is even if a bronchodilator may not be working, or if their attack is severe enough, the patient can enter what's called status asthmaticus. Um, and this is just when your bronchodilators aren't really working over the next 24 hours, and this is potentially an issue that a patient can come into. And even if their asthma is actually severe enough, and you'll see the patient kind of with the same symptoms, I guess. Their accessory muscle usage, having a hard time breathing, maybe even more so. They're starting to get wet and clammy because of how hard they're having to work just to breathe. And with this as an RT, it's been suggested that it's probably if things are just not working, it's probably pretty important to just intubate and help assist that patient so that they don't enter full respiratory failure, and then you're chasing tail to do that. And then another treatment that would help is Heliox, and that Heliox is a helium and oxygen mixture that helps to reach the upper parts of your lungs when you're starting to have those constrictions throughout your lungs. But yeah, that's asthma for you.
Yeah, a very common disease. Sometimes it feels like it's overdiagnosed in kids, but you will see a lot of asthma in the respiratory field, and you'll deal with a lot of asthmatic patients that don't really follow their care plans that they work out with their doctor, and it's unfortunate. It's a scary situation for these patients.
Yeah, it's actually something that's been affected a lot of my family members. My grandma has it, my dad has it. I have 3 sisters that have it, and I remember when one of my sisters actually entered status asthmaticus, and they were in the hospital for a couple of days just trying to keep her alive and keep her airways open. And so it's pretty scary for a patient to have to deal with that, and that's where I'm kind of glad to be able to help those patients out that have it.
Yeah, absolutely. Well, the last obstructive disease is emphysema. Now, you hear a lot about emphysema in regards to COPD because a majority of COPD patients do present with emphysema as well, just due to the fact that emphysema is commonly associated and caused by smoking tobacco. So, just quick summation of what emphysema is. You of course know your alveoli. What happens with those alveoli in emphysema is due to irritants entering your lungs down to the alveolar level. The walls in between those alveoli that make them very distinct and separate, those start to get broken down and destroyed due to inflammation. And this causes the small tiny clusters of alveoli to actually form, bigger singular masses. So instead of going from like, 9 functioning alveoli, you'll go to 1. Now, you may say, oh, it's bigger, it should work better, right? Well, because of the destruction of those walls, there's actually less surface area for gas exchange to occur. So, it actually leads to worse ventilation and oxygenation. Now, as emphysema continues on and progresses, it's not just the destruction of these air spaces. It also leads to the destruction of parts of the AC membrane. So you start getting fluid leaks into the lungs, similar to ARDS. Now, when this happens, you have, of course, the increased risk of developing an infection, a pneumonia, and when that happens, they have an exacerbation, and you'll see them in the hospital. Frequently, that's what happens with COPD exacerbations, is they'll develop this pneumonia from their emphysema. Now, of course, with any other obstructive pulmonary disease, there is air trapping and hyperinflation, which I don't think we've explained air trapping yet. But basically, what it is the patients can breathe in air fine, but due to an obstruction, thus the term obstructive disease, their airflow that they're pushing out isn't as much or as fast as it should be. Now, obstructive diseases are confirmed through the use of a PFT test, a pulmonary function test, which is a very vigorous set of tests that just assess the lungs. Quite interesting things to have done, though they I will say they do get a little boring if you do them all day, but it's an important part in diagnosing these diseases.
I think
Okay.
it's also these CBABE or the cystic fibrosis, bronchiectasis, chronic bronchitis, asthma, and emphysema. These are, when we say COPD, like these are the diseases we're talking about. When someone has COPD, they have these in some way or fashion.
Yes, absolutely. COPD is, as Trevor was saying, it is these diseases, but it's chronic, and it usually involves having 2 or more of these diseases, from my understanding. But we'll talk about that later, um, in the part 2 of this series of obstructive episodes. But yep, diagnosis of emphysema actually has a special test that goes with it on the PFT. The diffusion lung capacity of carbon monoxide. So basically, what we do is we actually give the patient carbon monoxide and then check for its levels in their blood to see how well it diffused. If it's high, they likely have emphysema. If it's low, they will likely have a different obstructive pulmonary disease.
So, Nick, just for my own personal clarification, if the DLCO is higher, does that mean that like they have emphysema, or if it's lower, do they have emphysema?
Sorry, I believe I misspoke. If the DLCO is lower, that means that they have a harder time diffusing the gas across the AC membrane. So it would mean that if they have a harder time diffusing it and the other obstructive markers are present, then it's emphysema.
Yeah,
So low
so,
DLCO, emphysema.
so I was looking that up in our textbook, and it says a normal DLCO is 25 milliliters of CO, and that's got a lot of other measurements behind that. But it's interesting that emphysema is the only obstructive disease with a poor DLCO. A majority of the time, isn't it related to a restrictive lung disease?
Yes, and you can easily say that it's related to restrictive lung disease because everything else besides these five obstructive diseases is restrictive. So if like there is um, anything that's affecting the AC membrane, making it so things don't diffuse across it, other than you know emphysema, it will be a restrictive disease.
Cool.
Well, I'm not with emphysema, like I said previously, it is mainly seen in smokers. I know that certain hazardous um, fumes can cause emphysema if exposed to them for a long period of time. Like some factory workers sometimes develop emphysema just because of some of the noxious chemicals in the air. But mostly it's seen with smoking. And with these patients, if you see them come into a hospital, they will probably be in a critical condition and will likely have to be put on a ventilator. Otherwise, emphysema can be managed with, airway clearance techniques, and of course, smoking cessation. But
And
once the damage is done with emphysema, it can't be repaired.
all these patients will have like you will be able to notice them the second they walk in the door. Like you'll be able to tell that you're dealing with the COPD, or they'll have classic clinical signs like bigger chest, uh, digital clubbing on their fingers. They'll be super skinny, um, but it's pretty noticeable.
Absolutely,
I'm,
it's
I'm trying to remember with emphysema specifically. There's like a term we learned. There's like your pink puffers and your blue bloaters. Isn't emphysema like our pink puffers or whatever?
yeah, I believe so.
Okay, it's such a fun word to say. Pink puffers, but I feel like blue bloaters. That's more of our chronic bronchitis, right?
Yep.
hmm
That's what I thought.
Well, that was just a shorter episode, but because COPD is such a broader topic, and we wish to go over smoking cessation, and we would certainly run over anyhow. This is where we're going to call this episode. Um, it is shorter, but we hope it was a good, quick look into the five obstructive diseases. And while we didn't get into everything, you know, hopefully you learned enough. But this has been Don't Hate Ventilate, and we will see you in the next episode for part two.